Hello, everybody. My name is Irfan Abas, and I'm very pleased that you're joining my webinar on immediate implant placement in the aesthetic zone. And this is a webinar for the MINEC. So thank you for joining us. I'm a doctor from the Netherlands. I have a private practice near Amsterdam. And besides my work, I have a passion for dental photography. I think it's the only way we can improve our surgical skills or our dental skills by making photographs and see what was the situation before and where we ended up. And from that, we can learn a lot. In the daily life, I have 4 jobs. First of all, I have my private practice near Amsterdam, where I have 2 other doctors, and our main focus is oral implantology and restorative dentistry. Before the coronavirus, I lectured quite often nationally and internationally. I did more than 35 lectures in 2019, and I hope to continue this the end of 2020 or perhaps next year, 2021. I'm also an author of 9 articles on oral implantology, and I'm also an editor for the Dutch dental journal called Tandartspraktijk. Last year, I started also my own private teaching academy. I have an 8-day full course on oral surgery and implant surgery. And this year, 8 doctors graduated from my private academy. So everybody wants to learn around surgery around teeth. And of course, that's a very sexy thing in dentistry. I think it's much more than just the surgical part. It starts all with the design of the implant, because we need to know everything we can do with our own implant system. So that's very important. Secondly, the planning and how we should perform surgery is very important. The location of where we want to place our implant and the direction of our implant is very important. And thirdly, the timing. At which moment in time are we placing our implant? Are we doing this immediately, delayed, or are we going for a conservative approach? And if we've chosen all these factors, then we can go to the surgery. And once we know what we want to do on beforehand exactly, the surgery will be very predictable and not so stressful for our clinician. Once the surgery has healed, we need to, of course, need temporary crowns, or I rather call them transitional crowns, to transition from almost nothing to a soft tissue which has the same emergence profile and cervical profile as a natural tooth. So we want to mimic the gingiva around our prosthetic. The timing of implantology is the first thing we get. Once a patient comes into our office, we do our CBCT planning, we do our intake, and then we need to decide if we're placing our implant immediate, so we extract and place our implant, or we're going for an immediate delayed approach. That means we're going to place our implant after 8 weeks, where the soft tissue have healed, but the bone has not fully resorbed yet, or we go for a delayed approach. That means 3 months after extraction in a healed site. So first we need to know what happens after extraction, and Professor Araujo, the guy on the left, did of course tremendous research on this part, where they have did in dog models study where to see if they remove the tooth, what happens with the buccal and oral ridge. And in 8 weeks time, we get around 40% resorption of the ridge. So the question is, if we remove a tooth, should we seal or not seal? Well, also from research from Professor Jung in 2013 in the Journal of Clinical Periodontology, where they had 2 groups. The one group, they removed the tooth and let that spontaneously heal. And with CBCT beforehand and after 6 months, they found that it can resorb up to 43%. If we have hard tissue resorption of 43%, the soft tissue will follow as well, of course. And we might end up with a situation with a bony defect which is visible in the mouth when the patient is smiling. And that's something we want to avoid. They also found when they did a socket seal, so in this case they put a demineralized bovine bone protein inside of the socket after extraction, and that meant after 6 months, the resorption went down up to 17%. So this might be less visible when the patient is smiling. But keep in mind that still there's some resorption, which cannot be counteracted. So the question is, can we take the risk of ending up in the left situation, or would we rather go to the right one? Well, my belief is we should try to avoid this situation. Although if we get in a situation that there is that there is a bone defect and less soft tissue, we need to know everything we can. We need to use all our instruments to get to a situation where everything is restored. But this might take a surgery or 2 or 3 sometimes to end up in this situation. So if we can avoid it for our patients, I think that would be preferable. So to get in a situation like this, we always need to know the 5-dimensional implant placement. So an implant should be correctly positioned mesiodistally, facial orally. The depth of the implant should be measured on the amount of bone and the relation to anatomical structures. And in the anterior maxilla, that's the incisal foramen in which the nasopalatal nerve is, and of course the base of our nose. And the implant should be in the correct relation with the opposing tooth. And we need to consider the bone density, because if we have hard bone, it's much easier to place the implant with an high initial stability, rather when we have soft bone, and we should adjust our drilling protocol or adjust our type of implant according to the bone. And for the aesthetic implant placement, we need more than 1.5 millimeters bone around our implant. We need a depth of 3 millimeters from the gingival height. That means that our implant should be positioned more to the palatal part, and that the neck of the implant should be 3 millimeters below the gingival height, as you can see here. Thirdly, we need to ensure that we recreate a correct cervical and emergence profile. And this is the emergence profile. In the previous picture, you saw the cervical profile. And this we can only do with a transitional crown to end up in this situation if we keep all those points in mind. So let us start to show you with a case where we have a width of more than 8 millimeters and a tooth which has to go. And I think this is a perfect example where we can go for an immediate approach. Our patient is a young female lady with a very high smile line. That means that if we have a higher gingival line here, or we lose the papillas, this is going to be very visible in the smile of the patient, and that should be something we need to avoid. If we look intraorally, we see a discoloration of the gingiva, and that's of course because of a discolored root which is beneath the gingiva. And if the root is shining through the gingiva, we can safely assume that this is a thin biotype. If we look at the x-rays, we see that the tooth has a little bit tilted to the distally, to the lateral incisor, but this is not enough information, because when we look at this x-ray, the only thing we can see is the direction of the root in mesial-distal direction. Here's also the incisal foramen, which is not visible on our 2D picture. But once we make a 3-dimensional picture, we make a CBCT. Now we can clearly assess where's the incisal foramen. We see the width, we see the thickness of the labial bone. We see that there's already been some resorption around this part. So this gives us much more information. And if we take into account the 3D pictures, here we have the curved plane reconstruction. Here we have the axial view and cross-sectional images. It's much more easy to plan our implant 3-dimensionally. So we can see that we need to tilt our implant more from distal to mesial to ensure that we will get our implant into enough bone so we can get high initial stability and the implant is fully in bone. If you look at this picture, you can see how large the incisor foramen canalis. But with the 3D planning, we know in which direction we should drill our osteotomy to avoid hitting the incisor foramen. So again, back to this case. So we need all these two-dimensional pictures to make a three-dimensional picture in our head. And normally I just plan virtually the implant, so I will know on beforehand in which direction I need to drill to get our initial stability. And as you see around this part, 50% of my implant I can get into bone, which can get a high initial stability. So first, before I start, I always take clinical pictures. I make models. At this time, I went to the digital side, so now I do an intraoral scan, but this case was done a few years ago where I did models, and I always have a reference tooth. This reference tooth will show me in which direction I've been drilling, and this is the direction I want to place my implant according to the alveol after extraction. So this is something I always keep in mind before I start my surgery. Then step by step, first I think it's important to cut into the gingiva. So we cut through the fibers, and that will prevent any rupture of the gingiva, as well as that the tooth will come out more easily, because we need an atraumatical extraction. In this case, I would not advise to luxate to the buccal, but rather to rotate the root, because it's an oval root, it can come out very easily. Secondly, I place my reference tooth, which I also can use as a temporary crown on my implant if my initial stability is high enough. And I place the temporary tooth on the adjacent teeth. So it has some wings on it, incisor wings. You can design this any way you want it to. And we have a small hole in which we know that's our direction for our implant. After extraction, we curettage the bone, so we don't have any granulation tissue or inflammation tissue inside of the alveol, and then we start. This is the direction of my implant. So I cannot drill in this side, because then I will end up with my implant too far to the labial side. So we need somewhere around 2-3 millimeters against the palatal wall. That's around here somewhere where I should place my first drill. And that drill is in this direction. And if you think that's too far to the palatal, this is exactly where I want to be, because if I'm going to the midline around here, my drill will end up here, and the whole buccal, the implant, will move to the labial side. And that's something we really want to avoid in this case. And then the second drill and the third drill, we still have a palatal direction, so we can make a screw-retained crown. We have our labial gap, so we can fill that up later on with a bovine bone material, and the direction is quite correct as we planned it. We wanted to go from more distal, a little bit that direction, and we're still avoiding the incisor foramen. In this picture, you can clearly see that I'm doing my osteotomy palatal of the alveolus that was around here. So in this direction, I want to place my implant. And if you open it up, if we enlarge this picture, we can see that it's almost a full osteotomy. So the implant will be fully in bone. And then we can place our implants immediately. I placed here a Megagen Enrich 4x13 implant. You can see the sharp crest. This is the kind of implant which will ensure we will get a high initial insertion torque value. So the initial stability is good. And I always make an X-ray directly when I place my implant. If it's in the wrong direction, I can always correct it. But I think the alveol went this part and we went slightly to the distal part. If I move the implant more to the mesial, I would hit the incisor foramen, and that could cause some bone loss on the long term, and that's something you really want to avoid. The ISQ value is very important. It's 7, but it's 76. If something went wrong there, I will correct that. But the ISQ value is more than 75, and that means we can load immediately. So what is an Icecube value? Icecube value means that it's a radio frequency analysis with a machine which gives us a value, and what it basically does is if the implant is fixed inside the bone, the movement of the smart pack will be very little and we get a very high number. Over 70 we can load immediately. If the implant isn't that stable in the bone or it's very soft bone, the implant might move a little bit more, and then the radio frequency analysis will give us a low value. That means that it's not suited for immediate loading, or even we need to go for a two-stage approach. So in this case, our initial stability was high, above 70, and then we can go for one stage immediate loading. Of course, it's a thin biotype. So after placing the implant, we need to fill up this gap with bovine bone. But because of it's a thin biotype, I took a small connective tissue graft from the tuberosity area. And what we basically want to do is we go in with a suture from the labial side, we go inside, we grab our connective tissue graft, we go back inside and we suture up, and we tightly fix the connective tissue graft in 3 spots. Once the connective tissue graft has been seated, I place a resorbable collagen membrane labial in between the connective tissue graft and the bone, the collagen membrane, and we fill everything up the bovine bone minerals. Because we have a high insertion torque value, now I want to preserve everything. If I just let it heal, the whole soft tissue will collapse. So if I can, I would load immediately. And there are several ways to do it. Because this case wasn't performed guided, I don't have a crown on beforehand, but I have my tooth reference, my reference tooth. And if I take a temporary abutment and I cut it off, and you need to cut this off around 2 millimeters from the incisor height, I can place my reference tooth again around there. There's an opening on the palatal side, and then this part I fill up with flowable composite. Once it's fixed, we unscrew it, and outside of the mouth, I fill up with composite, so I make a temporary screw-retained crown. What's very important is the concavity labial of the crown. If this is too convex, there will be pressure on the soft tissue, and I might get some recession, because we need around 2.5 millimeters of connective tissue to preserve the soft tissue. If we have less, we might get some recession, and that's something, in a case with a very high smile line, it's something I really want to avoid. Now the temporary crown is in place. I always use some disinfection gel inside of the implant. In this case, it's the Blue M oral gel we place in the implant, and we unscrew the temporary crown immediately. You can see it's slightly shortened. It's out of occlusion and articulation, of course, but we advise the patient not to chew or bite anything with their front teeth, because we still need around 8 weeks for osseointegration, and if the implant moves too much, it can de-osseointegrate, and then you will lose the whole implant. On the left picture, this is how the patient came in, and then 2 weeks post-operative, the patient comes back. The connective tissue graft healed very nicely. You see the 3 sutures, which is stabilizing the connective tissue, and the soft tissue came down a little bit because my implant was placed more to the palatal. Did the connective tissue graft, the whole soft tissue has been thickened. From this moment, we wait another 3 months, and in 3 months, you can see that there's no more discoloration of the soft tissue anymore, because we have ensured enough thickness of the soft tissue, and the implant has been nicely integrated. There's bone above the neck of the implant, and now it's time for unscrewing the temporary crown. So with the temporary crown, this is now looking at our cervical profile. You can see it should not be touching the adjacent teeth, because we still want some papillas around here, and if the papillas are too thin, we might lose the papillas. The emergence profile, The mesial papilla is the exact position as it was, and it's the same thing for the distal papilla. Remember, because of the old crown, we already had a 1 millimeter recession of the distal papilla. After impression, we need to make an impression, of course, with transfer the soft tissue profile to our dental technician. So we put some composite around our impression post, and the dental technician made us a individual titanium abutment. Nowadays, I would go for a zirconia abutment with a titanium insert. But in this case, aesthetically, there was no difference. And because I have enough thickness of soft tissue, this metal will not shine through the soft tissue. And you can see again the concavity to have enough soft tissue around here. This is now the definitive crown in place. You can see the soft tissue is very healthy. Everything looks very nice. And as we see from the initial situation, distal papilla is at the same height. The mesial papilla is at the same height. And this discoloration around the gingiva on the old tooth and the soft tissue around our implants looks now much better and much healthier. And this discoloration is mainly caused by the discoloration of the whole root. 1 year post-operative, the emergence profile looks well. Patient is keeping everything very clean. 1 year post-operative, we are happy with the result. The same is true for the bone height. We have more bone above the neck of the implant, and also there's any discoloration because of the titanium abutment we used in this case. And with that, we come to an end of my webinar. If you have any questions for me, just send me an email to irfan.abas@gmail.com. Thank you for joining me, and I hope you've learned something by this half hour. Till next time, bye.